Welcome. I'm Dr. Vinay Prasad. I'm a hematologist oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode, I've got an interview with Dr. Vinay Marini. He is a pharmacist at the University of Michigan, and he's going to walk us through every single recent AML new drug. If you're interested in AML, you won't want to miss this. Stay tuned. But first, a plug. On Plenary Session, we've heard listener feedback, and we're going to try something new. We're going to take our long episodes, and we're going to put them out piecemeal, little bit, just as you've asked. And then we will see what happens and how people listen. So, the experiment's on. If you like this podcast and want more content, follow me on Twitter at vprasadmdmph. Check out the YouTube channel, Vinay Prasad, MD-MPH. Patreon backers will get access to the slides for lectures I give on Plenary Session. Want to hear from us? Email us your question at plenarysessionpodcast@gmail.com. It's the holiday season here at Plenary Session, and that means it's time for our semi-annual pledge drive. That's right, Plenary Session is supported by Patreon backers. You got to go to patreon.com, find Plenary Session, and if you are a Plenard, if you're a fan of this show, you need to donate to this show to keep it going. Plenary Session has no other support. We don't do advertisements. We keep it pure, and so we are supported by small backers. So if you enjoy this podcast, you should support the show. If you don't enjoy this podcast, you shouldn't support the show. I wouldn't recommend it, only if you enjoy the podcast. I'm back in Plenary Session, joined via Zoom by Vinay Marini. Vinay Marini is a pharmacist at the University of Michigan Medical Center, and he specializes in the heme malignancies. He's clinical associate professor there. Vinay, it's a pleasure to finally get to talk to you.
It's a pleasure to be on the podcast. I'm a huge Plenard and a huge fan, so it's great to be here.
Oh, that's awesome. That's great to hear. And so you, is it fair to say, spend most of your time on the inpatient leukemia and lymphoma service?
Yep, that's a good assessment. So I primarily rotate on one of our two hematology services. So mostly acute leukemias, aggressive lymphoma patients, but other random hematologic malignancies that come up.
Places where we know dose-adjusted REPOC is better.
For all patients, always.
Always. Well, we're going to get into things. First, I think we're going to talk about some of the leukemia drugs, and then we're going to talk about perhaps some lymphoma drugs, if time allows. Where should we start? Let's start. You recently tweeted a slide. This was a slide that has been borrowed. Somebody put this together. Oh, I see at the bottom. Courtesy of Andrew Way, MBBS, PhD. So Andrew should get credit for putting all these Kaplan-Meier curves on the same plot. He actually color-coded them. He must have done something to digitalize it. I mean, he didn't just...
nice.
Yeah, he didn't just cut and paste it. I mean, I'm not exactly... Actually, the more I look at it, actually everything is formatted quite similarly. I mean, something's strange. I mean, he can't possibly have individual patient-level data for all these trials. I don't know how he's doing this. Any idea how he made this plot?
No clue. Sometimes when I'm making these plots, we'll trace over the curves in PowerPoint.
Yeah.
But this is
I thought
a nice figure.
Yeah. Okay, that's a good hypothesis. But I think the thing that will speak against it is he's got the censor marks. There's no way he traced all those tick marks.
No chance.
No
Not
chance.
enough time.
Yeah, no chance. All right, let's go through these. Let's start with the big one, the 7+3 midostaurin. This was a randomized control trial that came out a few years ago, the CLGB 1063 study. And this was a randomized control trial, which was 7+3 induction for FLT3 ITD, adding in midostaurin. It wasn't just, if I recall, it wasn't just FLT3 ITD, it was also FLT3 tyrosine kinase mutations as well. and it shows an overall survival advantage. And if you look at these curves, it looks like there's a few percentage points higher cure rate, maybe 5%, 4%. But if you look at the median, where the median falls, by chance alone, these curves skirt above and below the median, so that if you express this as an improvement in median survival, it was something like 20 months versus 80 months. It looked like amazing, right?
3 times better median overall survival.
Yeah.
It's dramatic.
And in fact, I think there are some people who had the audacity to put it that way. But of course, it's just because one curve is right below the median, one curve is right above the median. It's just hugging. But it looks like a 5% increase in cure rate. Or at least durable remission rate, because, towards the end, the curves kind of trickle a little bit closer. What about this trial? One of the things that I want to point out before I let you give your concerns is it's an unusual study, because my understanding is the cooperative group paid for it and not the company. And so the company's making a ton of money off the labors of the public. But there's some other issues in this study, like consolidation and things like that. What do you think about this trial? Do you use this drug? How do you interpret this study?
So I will say we do use this drug, but slightly differently than they do in the trial.
Yeah.
And there's a couple reasons for that. I think, overall, being a cooperative group study, it's hard to get people to agree on the best design. But I do think there are a couple of issues that make interpretation of this trial a bit challenging. So the first thing that we noticed in the trial is the daunorubicin dose that they used. Mm-hmm. So these were young, fit patients. These were patients, 18 to 60 years of age.
So they used 90 milligrams per meter squared.
Yep, exactly. They're using 90 milligrams per meter squared. But in this study, they used 60 milligrams per meter squared.
Bastard.
And I always hear the argument, there's 60, that UK study, 60 versus 90, but it's double induction. So it's really not the same as what we do here in the US. So I think that is one flaw. We don't know if 60 is the same as 90. It could be. And
we know 90 is better than 45. Isn't that the old Marty Tallman study? That was, I think Tallman, New England Journal, like 09 or something.
Fernandez, New England Journal,
right,
2007,
2007.
So that's the old ECOG 1900 trial.
Okay. And that was for people younger than a certain age, right?
Yep. So patients less than 60 benefited. Then there was a companion study in older patients, 60 to 65, benefited with 90 versus 45. So I think in general, less than 60, 90 is technically the standard dono dose in these patients. But I think they reduced with the thought that midostaurin would add toxicity. But then that's not fair in the comparator arm, where you're not adding midostaurin, you're giving placebo. So it's potentially inferior therapy there. I think that's probably the biggest concern.
That's your biggest concern. Okay. And I remember that when it came out, and I remember looking at the UK study, and your point's well taken. I don't think I had fully appreciated the UK is a double induction study, so that might obviate some of the benefit of 90 over 60. Okay. But talk about this for a second. Many people listening to this podcast will realize that, for a while we've had some dono shortages and we've had to use IDA and things like that. How do you come up with the equivalent dose, milligrams per meter squared, of IDA versus daunorubicin? Where does that calculation come from? Because I have always wondered about that.
Yeah, it's hard. We have some studies that have compared various IDA doses to dono. There's some suggestion that IDA even has a benefit over dono in certain studies. Mm-hmm. It is more toxic though, so it's really hard to find an equivalent dose. Mm-hmm. And so something like IDA 12 for 3 days, we'd consider technically equivalent to dono 90 for 3 days for most patients.
I see. And those studies that compare the two, though, they're not good studies. They're not randomized studies.
They're not the greatest. There's a lot of them. The dono doses differ. There's a big, I think, meta-analysis that compared the two, and I think they suggest there's a relapse-free survival benefit at the expense of toxicity for using IDA versus dono in those patients.
I got to look at that. Is it a meta-analysis of just randomized trials, or does it include a bunch of this garbage?
It is of just randomized trials, I believe. Right. I think there's actually a Cochrane review as well. But I haven't looked at the data in a while since we've had dono. That's kind of been our standard here.
So, go on.
I think the other issue with induction is in this trial they excluded patients getting azole antifungals. things like posaconazole, voriconazole, strong CYP3A4 inhibiting drugs. And we know in this setting of people with AML getting intensive induction, these azole antifungals, they also improve survival. So you're taking away one survival benefit to give another drug.
So what antifungal did you have to get here? Mycophenolate.
So you would have to get an echinocandin or low-dose fluconazole, I believe, in this trial.
Okay, I see. Interesting. You know, Bernie, when this trial first came out, I was making a big stink of 60 versus 90, and then somebody who seemed like they should know better told me rather firmly that they thought that was fine, and I let my concern go. But now that you say it again, my nagging concern, I knew I was sniffing around something. Okay, but the the POSA point you're making, I hadn't thought about that point. That's interesting. Because they're prohibiting that because, of course, it will interact with midostaurin, and so they don't want that. But by doing that, potentially they diminish outcomes in the control arm.
Mm-hmm.
You know, I mean, I think many people had expected more from midostaurin. Is that fair to say?
Oh, for sure.
Yeah, right.
I think, if anything, you know, this is a marginal gain of all marginal gains.
Yeah.
This is a pretty minimal benefit, like you suggest, with some major flaws that probably contribute to that minimal difference in outcomes. I think in our practice, the way that we're using it, maybe not the best. I mean, I do think the drug probably does prevent relapses. I think, you know, the goal of these patients is to try to get them to transplant for long-term outcomes. And so we don't use it in induction. It adds toxicity. It allows us to use Dono 90. So where we have been using it is in the consolidation phase prior to transplant. And that way, you know, those patients aren't at risk for invasive mold infections. And so you don't need to give it with azole antifungals. You can get the benefit in terms of potentially preventing relapse. With that being said, still using Dono 90 in induction. Although even doing that, I don't know if we're actually improving outcomes.
Right, I was going to say,
patients.
right. I see what you're saying. Yeah, you don't know that that's improving outcomes, but you're certainly not using it as they did in the trial. Okay,
No.
and then the last thought, midostaurin, just for the record, it's not a FLT3 targeted drug. It is a dirty TKI. I mean, it is one of the filthiest TKIs I've ever seen.
Dirtiest you get.
It's the dirtiest. It makes sunitinib look targeted, right?
Exactly.
All right.
Exactly.
Yeah. All right, let's go to the next one. CPX351. This is
my favorite.
My favorite. You know, because a 5-to-1 molar ratio is what sells a drug, isn't it?
Oh yeah, the most synergistic.
I think pure synergy.
Their preclinical claims are hilarious. That's probably what gets me the most, I think, salty about this drug. So that 5-to-1 molar ratio, if you ever look up that preclinical trial, it's the most synergistic in vitro.
The most.
But, you know, in certain times it's antagonistic, it's synergistic. It depends on the time course. Different ratios are actually just as synergistic, if not more. It's not the greatest preclinical evidence for providing a drug in a fancy $100,000 gold-plated liposome.
Yeah, right. Exactly. I mean, and to tell people, so this is the drug Vyxeos, and Vyxeos
yes.
is and what is the generic name? Liposomal.
So it's liposomal daunorubicin and cytarabine.
I see.
Not to be confused with all of the other liposomal products.
You know what? Actually, if I think about liposomal drugs in oncology, liposomal irinotecan, not worth its salt. Is there any good liposomal drug?
Liposomal vincristine.
Maybe Doxil? Maybe Doxil. Yeah?
Yeah. Well, that's fair. That's fair.
Okay.
I think that's fair.
Yeah, let's go back to CPX.
So you've got your 5-to-1 molar ratio.
Yeah, so that's part of the key. It's 5-to-1 molar ratio. Yeah.
5-to-1 molar ratio.
And
the other,
what is the molar ratio of 7+3? I actually never calculated it.
I don't know.
Okay.
It's different. It's not 5-to-1.
It's not 5-to-1. Yeah, okay.
And I think the issue is that it changes over time, right?
Of
so
course,
in the first 3 days,
yeah.
maybe have the optimal molar ratio or a better molar ratio, but then over time, that diminishes.
Okay.
The other aspects are it distributes more often to the bone marrow because it's liposomal, and supposedly, you know, going to tissues in bone marrow, that's better. But it probably also increases cytopenias, as we'll see in the trial.
Yeah, right.
The other major claim is when it's in the liposome, it's not effluxed by PGP. But if we know how liposomes work, as soon as it's released into the cell, it can be fully effluxed by TGP.
I know what the
That's
hell.
the dumbest argument ever.
I know. I mean, all these sort of pathophysiology arguments, the arguments that it has a, quote, selinexor has a novel mechanism of action, so it's so good. It really pains me because you're counting on the person not understanding that that's not actually a benefit of a drug. It's just a story you tell yourself, like you tell your children stories to put them to sleep. You're just telling a just so story so you can go to sleep on your mound of cash and sleep easy.
Makes us feel better.
Makes you feel better. Okay, so come back to this trial. So this trial, my understanding is it was there's an age restriction on this trial, and yet when the FDA approved it, they took away that age restriction. Classic FDA.
They took it away.
Silly. And there was a lot of treatment-related MDS turning into AML in this study, wasn't there?
Yeah. So it was patients aged 60 to 75. So it was these older patients who were still fit for intensive therapy. And this included therapy-related AML, so AML potentially due to prior chemotherapy or radiation, AML with a history of MDS or prior CMML, and then AML with MDS-related cytogenetics. So we kind of lump these in the WHO criteria into AML MRC, which also includes AML with myelodysplasia-related changes by morphology. And so the FDA approval has that cohort of patients in it, but in this trial, those patients were not studied. And they don't actually, we think, have worse outcomes than de novo AML patients just by morphology.
Okay.
And so I think that is one extrapolation that does occur based on this data that's probably not great, and the approval.
And there's something about this trial of consolidation. What was isn't there something interesting in this study? It's been a while since I read it.
Yeah, so they compared 7+3 to CPX-351 or Vyxeos. I hate using the name just because I think the drug is of marginal benefit. But in consolidation, they gave 5+2 consolidation in the 3+7 arm, which, if you query hematologists and ask, what is your standard consolidation for fit patients who you give intensive therapy to? I think most will say high-dose cytarabine consolidation.
Of course.
Yeah.
And what do you guys use in Michigan? What dose for your HiDAC?
We use high-dose cytarabine. We do dose adjust for older age. So when patients are above the age of 65, we generally dose reduce to 2 grams per meter squared.
Okay.
And then we dose reduce further when they get in the 70s and 75 range.
And we've had randomized control trials, I think, of consolidation doses of cytarabine, have we not? We've had a couple New England Journal studies, I remember, for about a decade ago.
Yeah. The first study is the Mayer study in New England Journal in 1994. So this is going way, way, way back.
Yeah, I don't know if
and that compared HiDAC.
No, I think I did read it, yeah. Go on. HiDAC?
3 grams per meter squared to intermediate, or I would say standard dose cytarabine. So I think at like 400 milligrams per meter squared, 500 milligrams per meter squared. So pretty low doses, continuously infused for 5 days. And the high dose cytarabine had a survival benefit in younger patients in that study. There's some major flaws to that study that I think we kind of ignore. And so we know 3 grams per meter squared is better than lower doses, but I think the in-between is a huge unknown.
Of course, yes.
Yeah.
But there's another study, I thought, about a decade later, an intermediate dose study.
There's a lot of European studies that look at intermediate doses. And I think the problem with a lot of these and extrapolating to the US is their use of double induction as well, which makes it hard to kind of cross-trial compare what's the best cytarabine dose. I really think we don't know. But I do think in general, most people in the U.S. are not giving 5+2 consolidation.
5+2 is trash.
I think,
trash.
I think they looked at the NCCN guidelines and they picked literally the worst option.
Yeah. So bottom line it for me. And the other thing is, I think some people are giving CPX 351 to people who they think would otherwise not be fit enough for induction, which I think is just totally crazy.
It's crazy.
It's totally crazy, and that's not what the trial did. And then the other thing is, some people think it's like you have to give it if anyone has treatment-related MDS, if anyone has treatment-related AML, you have to give it. You can't give anything else, and I think that's also crazy. So do you use it at all? Who do you use it in?
We never use CPX 351.
Right,
so
fine.
We actually we anticipated this drug coming out, and we recognized that these secondary AML patients, they don't respond that well to 3+7, although they do better than they did in this trial. their response rates in other trials are typically around 45%, not, the 33% they saw in this trial. So we started using FLAG in our patients, so fludarabine and high-dose cytarabine. And that's tolerated in patients, up to their 80s. There's no anthracycline in that regimen, which we know doesn't work quite as well in these secondary AML patients. And we did that because the goal of these patients, if they're fit for chemotherapy, is to get them to a stem cell transplant. And we figured, why beat them up with 3+7 if FLAG is going to have, about a 50% response rate in this setting as well? We can get them to transplant. We can keep them in remission. So we conducted a study at our own center comparing FLAG to 3+7. We called it the Fossil study. Have to give it a cool acronym, cool nickname.
Of course.
Otherwise, nobody will remember it. And then recently, we did a multi-center study with a collaboration of pharmacists from around the country looking at high-dose cytarabine-based regimens. So high-dose cytarabine plus a purine analog, things like FLAG, CLAG, etc.
Yes.
Compared to CPX-351. And we presented the data at ASH last year, but it was a non-inferiority design to show that response rates are just as good with something like FLAG that maybe cost you $1,000 compared to something that costs, upwards of $100,000 with no difference in survival outcomes. So that's what we use in these patients that are fit for chemotherapy. We use FLAG chemotherapy.
But wait, you're saying the study that you ran, is it randomized or?
It's not randomized. So I think our issue is funding.
Of course,
there's no incentive to do a trial like that.
I know. I know. It's kind of interesting. I mean, there are so many studies one could do, and the studies we get done are the ones where the for-profit companies back it. So CPX-351, is that Jazz Pharmaceuticals?
Yep.
Oh, of course. All right. Well, that's enough about that. CPX-351, I say thumbs down. Okay.
One other thing I want to mention, because I think this is getting a lot of hype at ASH right now on Twitter. They continue to talk about their post-transplant outcomes and how great they are. Oh, people who get Vyxeos, there's something about the drug. They do better post-transplant. But if you look at the patients that went to transplant in both arms, there was about double the amount of patients going to transplant with active AML in the control arm compared to the Vyxeos arm. So it's all about transplanting people with active disease.
And not the Vyxeos itself, right?
And not the Vyxeos
And if you give them FLAG or something instead, maybe you'll lower that rate.
Or HMA.
Or HMA, yeah. I would say the problem with this space fundamentally is, that the doctors, they can be seduced by these kinds of messages that anyone who spent time doing data analysis would know is just nonsense, or there are a million other potential explanations for it. Okay, next drug. Glasdegib. This is garbage. I mean, come on, I can't even read Glasdegib. The control arm is garbage. Low dose Ara-C, get out of here.
It's awful.
That's an inferior. It's a known inferior regimen.
It's awful.
Bernie, your thoughts?
I don't even know if it's worth discussing.
Okay.
Glasdegib, people hate taking it. It makes people's taste change. It's just an awful drug. I never used it, never will use it. Inferior strategy. I think maybe the niche they're trying to go for is people with, poor risk AML. Maybe it's a different mechanism of action. But in those patients, in the high risk cytogenetic patients, there's no difference compared to low dose Ara-C. So even in the patients where you might use it, you'd never use it.
Yeah.
So.
Ridiculous. Okay, let's talk about the IDH inhibitor, Aza plus anacetinib.
I think this trial is hilarious because the EHA presentation last year, and I think that's where this survival curve comes from. The title of it, is something like anacetinib improves overall response rates and event-free survival rates in these patients. And then you look at the overall survival curves, and they completely overlap. There is no benefit to adding anacetinib to HMA therapy. And I think these are the IDH inhibitors that were approved first in the relapse refractory setting based on essentially phase 1/2 trials.
Yeah, showing about
a 20-25% response rate.
Yeah.
And I think the problem with these agents is they take so long to work. They take 2 to 3 cycles, 2 to 3 months to see any effect.
Yeah.
And often, 6 months or more to see complete remissions. And I think, the cost is $30,000 a month for these drugs?
Unbelievable. So I guess I would say that, these drugs have been so touted. I mean, these IDH inhibitors have been touted. In fact, some people even go as far as to say it's a reason why we were right to teach you the Krebs cycle. I'm like, get out of here. Get out of here. I mean, you don't even need to know the Krebs cycle to know that somebody has an IDH mutation with AML. You should consider it in a salvage setting. And then the initial trials were those randomized trials, I think, of like best supportive care versus the drugs. They all had meager survival benefits, no curative fraction. Is that an accurate characterization? Very meager, couple months.
Yeah, I mean, the original trials, there's no comparator.
Well, there's no comparator,
which is hilarious. I mean, the FDA approved it with just a response rate. They said, "Hey, we have a targeted therapy here. We have to approve it."
Yeah, and that's one of the problems. And then now we have the AZA. We'll see. There'll be more trials. Maybe they'll eke out some benefit somewhere. But they're not transformative drugs. They're not curing people.
No.
They're not. People talk about the toxicity not being so bad. Perhaps.
Exactly.
But I mean, you could have given these people just AZA, and that toxicity is obviously tolerable because the control arm is getting just AZA.
Yeah. And what are we going to see in the future? Triple combo. We're going to see HMA, Ven, and these IDH inhibitors.
God. I think it'll be quite toxic, actually.
Oh, yeah.
Okay, let's talk about 7+3+GO. Gemtuzumab ozogamicin. How do you say it? Yeah. Ozogamicin.
I think.
Yeah. My favorite drug because it was approved 9 milligrams per meter squared. Randomized trials at 6 milligrams per meter squared. Didn't look so hot. Failed. They pulled it off the market. Then 3 milligrams per meter squared. It's got another go. Yeah. So what's this alpha study? 0701. Yeah.
This alpha study, I mean, this study came out in the interim from the drug being pulled from the market and then reapproved a couple of years ago. And when it got reapproved basically out of the blue. There was no new data to say, oh, this should be used.
Yes.
But everybody references this alpha trial. So this alpha 0701 study, this was a trial of 7+3 with or without gemtuzumab ozogamicin. And this was a French trial. And the thing they did to mitigate the veno-occlusive disease, which is the major limitation to using this agent, is they split up the gemtuzumab dose. They fractionated it. So you give 3 milligrams per meter squared at a time to try to limit that VOD. It still occurs, and it still occurs more commonly in gemtuzumab patients than in placebo patients. And so they conducted this French trial. Again, a major issue of this trial, and these patients were 50 to 70. So, half the patients in this trial, the dono dosing was potentially suboptimal. They used 60 milligrams per meter squared again. So it's another trial where they're lowering the anthracycline dose to give another targeted, let's say, agent. I think the other issue in this trial then as well is in consolidation. It's not your standard high DAC consolidation with 3 grams per meter squared. It's intermediate dose cytarabine plus an anthracycline plus gemtuzumab. So it's not quite the same of what we do here in the U.S. And then initial trial, which was published in Lancet in 2012.
Yeah.
So this was well before it got reapproved.
Yeah.
Showed an overall survival benefit in these patients.
Yeah.
But then when they did longer follow-up, and this was published in Hematologica in 2018, there was no survival benefit.
Vanished, right? Okay.
Exactly, because these patients can be salvaged with high-dose cytarabine-based strategies. So I think this was a trial where initially there was a signal, maybe there's a survival benefit, but then in longer-term follow-up, these patients can be salvaged.
Now, some people say that there's there's this meta-analysis that looked at... and then they specifically recommended for favorable risk patients. What was that? What was that meta-analysis? Or there's a certain, or was it inversion 16 or something? Some specific.
No, you're exactly right. So this is the Hills meta-analysis in Lancet in 2014.
Yeah.
And this meta-analysis looked at, it essentially included this alpha trial, the Petersdorf SWOG trial, and some UK trials, and one other French trial, I think, of gemtuzumab compared to standard therapy in AML. And in the meta-analysis, there was a survival benefit in intermediate risk, although if you look at the curves, they're eerily similar. I think, at 5 years, it's like 35% versus 33% survival in intermediate risk, so potentially no benefit there. But in favorable risk, there was about a 15 to 20% survival benefit in patients getting gemtuzumab. But I think the problem with this meta-analysis is it doesn't contain the updated data from the alpha trial. So it's got old data in it from the trial where originally it did show a survival benefit. Now it does not. That data is all not in the trial. I think the other issue is in a lot of these regimens, you're not comparing 7+3 with Dono 90 and HiDAC at 3 grams per meter squared, which is what we do for our core binding factor patients.
Right.
You're comparing suboptimal therapy to suboptimal therapy plus gemtuzumab. So yeah, if you want to use, suboptimal therapy, you probably should add gemtuzumab to it. But if you're going to stick with, standard Dono dosing and HiDAC, there's really no benefit to the addition of gemtuzumab that we know of. And it definitely adds toxicity in young, curable, fit patients.
So you don't use it?
No, we don't use it.
Okay. Gilteritinib. No, sorry.
Gilteritinib.
Sorry, let me say it again. Gilteritinib, the Admiral trial, yes.
The Admiral trial, yeah. So I think what's funny gilteritinib is a FLT3 inhibitor, inhibits both FLT3 ITD and FLT3 TKD. So this was studied in patients with relapsed or refractory FLT3 positive AML. Most of these patients were FLT3 ITD patients. There were some TKD patients on the trial, and they randomized them to physician's choice therapy versus single agent gilteritinib. And of the physician's choice therapies, I think this is where this trial maybe suffers. The options were low dose Ara-C, which, come on.
It's garbage.
Stop doing that, please.
Stop doing that. It's criminal.
Azacitidine, which azacitidine in relapse AML, not the greatest option.
Yeah.
MEC or FLAG. So MEC is mitoxantrone, etoposide, and cytarabine. So two very, very intensive toxic regimens where you don't always want to include an anthracycline in these patients versus potentially inferior therapy like low-dose cytarabine and azacitidine. So,
it's interesting. So what it'll do is it'll take people who you would have pushed a little bit harder and you drop them to the lowest because you don't want to go to the highest.
Exactly.
Yes.
So that's the issue. There's a lot of people where you're like, I can't give this patient MEC, but, I could give them FLAG. I could give them some intermediate base therapy. That's chemotherapy that still is not MEC.
And why can't you give FLAG if you can give FLAG? I'm so sick of this, like, they call it investigator choice, and then they restrict the choices in a way. I'm sick of this. In every study, they have these garbage investigator choices, like I think in like BRCA breast cancer, but you can't give platinum, or like, what the hell are you doing? They're just taking away the things that you would want to give. Okay, very interesting. Okay, comparator regimens are either really toxic or inadequate, if you ask me. Exactly. Oh, I see in your comment you mentioned Quizartnib. Quizartnib is, that trial had so much censoring. It's so much, we did a paper recently on imbalances in censoring, and Quizartnib was like off the charts bad, and the FDA pointed it out, and it didn't go anywhere for good reason.
Yeah, good reason. I agree. I think the Quizartnib trial and the Gilteritinib trial are eerily similar, yet we approved one and did not approve the other.
Yeah.
And I think if you look at the overall benefit of gilteritinib compared to chemotherapy, it's not that much different than they saw in that Quizartnib trial. And that's something like 9 months versus 5 months.
Yeah.
I think that's potentially
very,
one of the very, very marginal benefit. And I think probably one of the biggest criticisms is how poorly the standard arm did in these trials.
Yes.
I think the CR rate with chemo is like 15%. And I can't say that our response rates to chemotherapy in this relapse refractory setting are 10 to 15%.
So, I mean,
they're more like
one
50%.
commonality that you've highlighted in several trials, from the midostaurin study to CPX351 to gilteritinib, and even to the alpha, or even to gemtuzumab, is if you don't do a good job with the control arm, yeah, some of these agents might eke out a benefit, but that doesn't really inform our practice because we do a good job with what we're doing. Fair to say that's true in all these 4 studies.
Totally agree. And I think that's one of the most insidious issues with these trials is that they appear to be good. You know, they're a randomized controlled trial against physician's choice.
Yeah.
How can that not be the best trial design?
Right.
And until you really dig into these studies,
right.
do you point out all the flaws?
Yeah. And I find that every year that goes by, I see that more and more, to the point where, you know, I've concluded that the person who stands to make $4 billion from the sale of a product just can't be the person designing the trial. They'll always find a sneaky way to run a crappy study. They'll always do that because they have so much incentive to do that. You have to have some independent third party. Even then, as we saw with the midostaurin study where it is an independent group, they're not really independent because they're dependent, I think, on the company for donating drug. So they got to kind of play to their whims. And many of the investigators are probably conflicted. I mean, in fact, I'm sure that is the case. So you need true independence, which we just don't see in oncology. Let's talk about CC486, Quasar. Your favorite drug, oral AZA. It's
oral AZA.
And now with oral AZA, oral Ven, it's an all-oral regimen. You're ready to go home with AML. It's so good.
It is coming. It is coming for sure.
Yeah.
So this oral AZA trial, I think one of the most frustrating things is this has not been published yet. This has been approved. We've had press releases. We've had an ASH abstract last year. We still do not have the publication. And I think there's a lot of hidden messages going on, and we're missing some of the key pieces that we need to know from this trial. So this was a trial of patients who had newly diagnosed AML. They were 55 years of age and older. They had intermediate or porous disease because, you know, favorable risk disease patients, we just give, you know, high-DAC consolidation, right? They shouldn't go on to maintenance therapy.
Right.
And these were patients who were essentially ineligible for transplant, we said. You know, even though they had porous disease or were intermediate risk disease, they were ineligible or they didn't want to go to transplant. So for some reason, transplant, the investigators decided wasn't a good idea for these patients. And I think the biggest flaw in this trial is they did not require consolidation in these patients, which we know in AML. I mean, we've known this since the 70s and 80s. If you just give someone induction and you give no consolidation therapy, every single patient will relapse.
Right.
You need to give some consolidation therapy. So, you know, this has a lot of similarities to the POLO trial, where you took people responding to effective therapy and you put them on maintenance or placebo. I think there's so many similarities in this trial compared to something like that.
So wait, remind me. Of course I haven't read it because it can't be read. Quasar AML, what was the induction they received? So,
I don't think there was a standard induction, but it had to contain anthracycline, I believe.
Okay.
I can check really fast.
Actually, I'm going to check too. Okay. The study enrolled 460 people aged 55 or older with de novo AML, secondary to MDS or CMML, who achieved CR following induction with or without consolidation chemotherapy, with or without. And then it randomizes them to oral AZA or placebo. Interesting.
Yeah, so I don't believe you had to.
It could be anything.
Have
randomized to receive or placebo. What the hell is this placebo nonsense? Okay, let me read this.
It gets worse. It gets worse.
Eligible patients within 4 months of attaining CR/CRi, they're randomized 1-to-1 to this or placebo. 21-day dosing schedules permitted. Okay, sure. Primary endpoint is OS. I guess it is smelling like polo, huh? Because
very much.
And 86% had intermediate risk and 14% had poor risk cytogenetics. So they're not all poor risk. Okay.
And what would be your estimate? Like if you had to estimate how many of your AML patients get 2 or 3 cycles of consolidation, would you say that's the goal? You know,
certainly is the goal. I guess I should say, you know, I've only ever been a leukemia doctor as an inpatient attending. It wasn't part of my outpatient practice, but I attended on it for all the years I worked in Oregon. And I follow it intently and closely, and I'm very interested in the inpatient, at least the acute decision-making that comes, which I think is the most interesting part.
Totally agree.
And I guess I would say that, I'm just thinking through this right now, I mean, I'm trying to think, like, who would I actually be comfortable with putting on placebo? It's almost unheard of. I mean, unless something happened while getting consolidation. Yeah, I just don't see. And even then.
Yeah, so I think in that population, you'd think, if someone is maybe unfit, they have a bad event in consolidation, and you say, I want to put you on maintenance. I think the other question is
why not give them AZA?
Why not give them AZA? Or why not wait? Monitor the patient closely
until they relapse.
Give them appropriate post-protocol therapy. If they're already doing poorly, giving them therapy forever maybe isn't the best use of resources and quality of life if that patient initially had a poor run with consolidation therapy.
That's a good point. If anything, I mean, this trial probably is taking people who are fit enough to get consolidation and not giving them consolidation, is my guess.
Correct.
That's your guess, too.
Yeah. And the numbers here are, I think, really interesting. So 20% of patients got no consolidation. 45% got one consolidation. So that's already 65% of your patients got zero or only one consolidation which is inadequate. Cycles.
You know what?
Exactly.
I mean, look at the way the trial is done. It's a feature that's common in Polo in this trial, which is, Polo is you had to get at least 4 months of therapy. And this trial, you could have gotten consolidation. But imagine being the person, like when you're the person in the doctor's office, if the trial has an open slot now, you're going to want to jump in and take it, even if what you really wanted to do was get a little bit more consolidation under your belt before you jumped in the trial. You know what I mean? Like
exactly.
The way the incentives are around all these trials is to deprive patients of therapy because I'm not sure, but I have a feeling that the doctor is going to be like, well, we have the trial open right now, and if you got a couple more consolidation cycles, I don't know if it would still be open. That kind of thing. And I think people are naive if they think that kind of thing doesn't go on. It goes on quite rampantly because people have a huge incentive to get people on these studies, financial, non-financial. It's a huge problem. I mean, I think anyone who's been a fly on the wall at many of these consent meetings wants to sometimes vomit because it's a lot of nonsense being said. So I think that is a subtle way to sabotage someone's consolidation here. Interesting. Okay. We got one last one to go.
It gets worse. Sorry.
I
just want to harp on this a little bit more. So
finish it off.
I think one of the things I learned from your podcasts and many others, we have to pay attention to what these patients got after. What was their post-protocol therapy, especially in the placebo arm, right? So I think what's interesting about this trial, and this isn't published yet, but this is information that the company, gives out and calls, is, and this is something they haven't talked about, and we need to see the data, is on what proportion got appropriate post-protocol therapy. And I think the number was pretty high. I think it was like something like 70 or 80%. It was a decent number. I mean, it should be 100% of patients. But I think what's scary is in that number, they're including low-dose Ara-C, again, as potentially appropriate post-protocol therapy, and Hydrea. They counted Hydrea. Oh, yeah. Yes. I'm not kidding. So Hydrea was counted as post-protocol therapy. And this isn't a small fraction, like 1 to 2% of patients. We're talking like 10 to 20% of patients getting basically nothing. And then the other interesting part of this trial is they have this second phase. So let's say these patients are on maintenance or they're on placebo and they develop 5 to 15% blasts, which is AML relapse. When you have that amount of blasts, you need to be retreated in this setting. I mean, we know that. So if you're on the placebo arm, you have the option to get more placebo. If you're on the oral AZA arm, you have the option to escalate your azacitidine to 21 days. So to get more azacitidine. And that didn't happen in like 5% of patients. That happened in, I think, 17% of the placebo patients. It was like 20% of the cohort overall received this ramp up. So in the placebo arm, when they relapsed, 20% of them got placebo again.
More? Wow, really? Where did you get this data? Where's this coming from?
So it's a subset of the study.
Yeah.
Of in patients who had, I tweeted a picture of this.
Yeah.
So there's an arm, if you relapse with 5 to 15% blast, you weren't called a progression, and you had the option to increase your AZA dose.
So it's just
or
another
if
way.
you're on placebo,
You increase the placebo dose.
increase your placebo dose. And if you had over 15% blast, that was a progression.
This is ridiculous. That's so unethical.
It's so bad.
It's so bad. Oh, so bad. These trials are so bad. Oh, God.
I know.
All right, let's do the last one before our time runs out. This one I actually had.
Azaven.
Yeah. I thought was decent, but you found something.
Yes.
But it's not as egregious. It's decent.
No, it's definitely not as egregious.
Okay.
I think so. The Azociting Venetoclax. So initially, it was studied in a phase 2 trial, either azacitidine or decitabine with venetoclax, and it was approved based on that phase 1/phase 2 trial, based on a survival rate of 17 months. Which, as a baseline, if you give somebody hypomethylating agent alone, you're looking at about a year of survival. So they saw, 5 months longer in a phase 2, approved the drug. Response rates were not any better in that trial than 10-day decitabine. If you give 10-day decitabine, you're talking 50 to 60% response rates. So it's based on that improved survival. Well, it's based on that promising survival in that phase 2 study. So then they did the phase 3 trial, and I'll give them credit. This was a fairly well-designed trial.
Yeah.
I think there are just a couple of issues and questions, mostly with people extrapolating this data to populations where I think it doesn't quite fit.
Like fit people can get 7+3.
Exactly.
Yeah.
So yeah. So this was in patients who, were older or who were unfit for therapy, and they randomized them to azacitidine with placebo or azacitidine and venetoclax, and there was an improvement in survival from something like 14 months to 9 months in the placebo arm, which it is a significant survival improvement. It's not, I think, the game changer that everyone talks about it like, and it's probably not the reason to add venetoclax to everything because of a 3-month survival benefit compared to azacitidine alone. But it is a fairly well done trial. So I think this does have a role. I think the issue is in extrapolating it to young, fit patients, because I don't know that the remissions are as deep as giving this to people who are young, who can get intensive chemotherapy.
Yeah, I certainly think they have not shown that yet. Your point's well taken. Do you do a lot of 10-day decitabine, and do you do it 5 and then give them the weekend off and do 5 more?
So we do a lot of these patients, ideally you treat them outpatient, right? But so many of these patients are so sick that you need to treat them inpatient when they're in the hospital. And I think that's also kind of a marketing thing with this HMA-Ven combo is you can deliver this entirely outpatient. It's all outpatient therapy, but some of these patients, they never recover their counts.
Let's talk about the counts. Their counts go to shit. I mean, it's a disaster.
Terrible.
The counts are a disaster. And then then you really have to, then they spike a fever and it's over. They're in the hospital a long time.
Yeah.
Long time.
Yeah. So they end up in the hospital, I think, longer than we intend. And so for someone who's transplant eligible, and who is fit, this isn't something that's going to always act very quickly. And someone who's older and maybe unfit and just wants to go home, if their counts are normal at baseline, this is great, right? We can get them home. They can be transfused. But in some patients, their transfusion burden is so high. If you give them HMA and Ven, they're never going to leave the hospital. There are some patients, like we treat patients up in the UP, they can't travel down to Michigan to get, outpatient decitabine and venetoclax. It's just too challenging. So in some cases, we have to use intensive chemotherapy. We can't always use this regimen.
The last thing we didn't talk about is sorafenib for FLT3 after transplant. I saw this there's like a Chinese randomized controlled trial. There's another very small study. You use it or no?
We do use it. I will say that I think there's some issues in the trial. A lot of these retrospective studies, there's a massive immortal time bias. If you're on the sorafenib arm, you survived, you had no GVHD, you did great. And so we put you on the sorafenib arm. And the control arm, these patients, these are the patients who aren't fit enough to get sorafenib. And so I think that's one issue with the data. But we have been using sorafenib for a long time. I don't routinely round or get to influence the BMT group quite as much as our hematology group, which I think is really strong. I mean, I'm lucky to get to work with, several great pharmacists, Anthony Perisonati, Lydia Benitez, and others who really influence practice on the hematology side with me. And our attendings are fantastic.
This has been a helpful discussion of some of the things that people don't talk too much about with pretty much all of these drugs. And if I were to say the take-home lessons are, one is something that we've written about. Rachel Cook was a leukemia doctor at OHSU, and Jenny Gill and I wrote an article about patients who are, quote, not eligible or can't tolerate aggressive induction treatment. And that's just like such a loose and capacious category that people just push that into everything. And one of the things is when you come up with a new shiny fancy drug for people who cannot tolerate the induction regimen, and the company comes and just really pushes the hell out of it, there are going to be all these people on the margin who probably in the past you would have given aggressive induction that you're saying, it's okay, they can get Aza-Ven, and you may actually erode outcomes even though the drug may actually be beneficial in the people who are truly ineligible for aggressive therapy. And that's sort of just a totally misunderstood point. The other point I think that you're making that's super important is many of these studies, CPX, GO, midostaurin, they are dogging the control arm. They're just not doing as good a job as we would. If we weren't participating in those studies, we wouldn't be too happy with that control arm. You pointed out a really interesting one to me, Quasar, where you had 4 choices, but two, it's like the story of Goldilocks. 2 were too hot and 2 were too cold, and you didn't get the bowl that was just right for you in the control arm. And what that leads to is, if the choice is between too aggressive or inadequate, the doctor is going to say, let's just go with inadequate so we don't have to deal with all that toxicity. And so you're going to get inferior outcomes. And not to mention, you pointed out that when you did have relapse, that you could have a dose escalation of placebo. That's just simply madness. That's a madness move. I mean,
it is a madness move.
Next, they'll say you can shoot the patient in the control arm. I mean, where does it stop? Where does it end? The harm. So, I mean, these trials suffer from this problem, and this is the problem I see throughout medicine. In this particular space that we've discussed, I would say these are two-steppers. You got to be a pro to catch all these. I can't admit, I have caught some of them, but I didn't catch them all. So I'm glad that you're here to show them to us. They do affect interpretation. I think you need to be judicious. And so let's bottom line it. Glass-Degib, we never need to use that. CPX, you never need to use it. Never use. Nope. GO, you never need to use it.
Nope.
Midostaurin, maybe. Aza-Ven, sure.
Yeah.
Aza-Ven,
in the right patient.
In the right patient,
in
sure.
the right patients.
Gilteritinib, no. Veto.
So we get more data.
And the Idh inhibitors, more data needed.
Yeah. I think that's a great bottom line. And I think, I think in oncology, we're at this space where, we have all these agents with marginal data, everything's getting approved. And it's really got to be up to us to try to control this, to try to decide, this drug that's approved with a marginal gain, if no gain at all, we are not going to use this regimen. And that's what we've started doing. We call it oncology stewardship, kind of like antimicrobial stewardship, to try to control the use of some of these things. Because I think, the bar, as you've talked about 1,000 times, has been, there is no bar anymore.
There is no bar.
Let's be real. There is no bar. And so, it's important for us to critically evaluate the literature and make sure that we're not harming our patients. I mean, we got to do what's best for our patients.
Yeah. You call it stewardship. I call it, evidence-based medicine. People call it different things, but it's all, once upon a time, this stuff wasn't so, it's common sense, right? Which is that if you want me to use new $400,000 a year drug, you really have to show it's better than old $20,000 a year drugs in a very, very fair study. You can't run a race and shoot your competitor in the foot and then say, I ran faster, see, I'm the winner. And that's what you see over and over in these studies. And these ones are a little bit more nuanced and tricky. But they're just as important. And of course, we didn't talk about cost, but the cost of the care of acute leukemia is just tremendous. It's just tremendous cost. I mean, maybe only myeloma dwarfs it, and transplant, and CAR T. Okay, we got to do it again. And when we do it again, we got to do T-cell lymphomas, CD30 drugs. We got to do
tafasitamab.
Oh God, yes. Garbage.
Pola.
Oh yeah. Oh, come on. Pola BR I've already taken to task on this.
Oh yeah, you did.
Tafasitamab, and the control arm, what? They don't get Rituxan, do they? They don't.
No.
Crazy. Okay. We've got the R squared, of course, everyone's favorite. We got to talk about double hit. We got to talk about Dosage Epoch. We got to talk about that. We got to talk about brentuximab.
The ALL space is blowing up too.
Yeah.
Inotuzumab, blinatumomab. There's so many flaws with this Blin MRD data that people just ignore.
Yes,
I think it's because
agree.
we're so, we're so starved for drugs. Not that we actually are, but people wanted something new in oncology.
Yeah,
they wanted something
spaces.
new in AML, right?
Yeah.
In leukemia. So anything they just want to use. Nelarabine, God, that data is so bad.
So bad. So we will be back and we'll do a lymphoma episode, and then ALL is above my pay grade, but I can do it. I can do it. It's a good space.
But yeah,
Bernie, thank you so much for this tour of AML drugs. So we're gonna put this out soon. We'll see who's intrigued.
It's been a pleasure.
All right, we'll talk more again.
All right, cheers.
You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.